Okay, so bempedoic acid is an oral agent, and the target for bempedoic acid is an enzyme that is 2 steps up from the target of statins. So that means it's actually the same cholesterol synthesis pathway in the liver. So it reduces cholesterol synthesis and produces LDL cholesterol receptors, and thereby lowering LDL cholesterol. The reason that clear harmony was very important was that all prior studies with bempedoic acid had shown reductions in LDL cholesterol, but the follow-up was relatively short, so 12 weeks. So when you look at safety, you need a larger study with longer follow-up. So here we had 2,230 patients with a follow-up of about 1 year and randomized 2-to-1 bempedoic acid or placebo. And importantly, these were people with established cardiovascular disease or FH, with very high LDL cholesterol, i.e. above 1.8, and these patients were receiving maximally tolerated statins, including 50% on high dose. It was a randomized, parallel design, placebo-controlled trial, so the largest exposure to date with bempedoic acid. And I think the reason that the study design is so important, because with statins, when you double the dose of statins, you only get a further 6% reduction in LDL. But actually, at the limits of the high-dose statins, toxicity starts to go up, muscle, liver safety. So if you're working through the same cholesterol pathway, it's actually really important to show that you get maybe more than a 6% reduction, and also that you don't get the liver and CK abnormalities. The other important thing about bempedoic acid is, in order to be converted to the active compound, you need an enzyme which is not found in skeletal muscle, and therefore you shouldn't get the muscle side effects, and that's an important discriminating factor with statins. So the primary endpoint was overall safety. So to look at whether bempedoic acid versus placebo increased risk of adverse events, and there was no difference in that. When you look at serious adverse events, again, they were equal between the two groups. A few more people discontinued study drug in the bempedoic acid group, but that didn't appear to be related to any particular system and organ class, meaning that it could still be a chance observation. The only thing that was observed is a small excess risk of gout, but the rates of gout were very low in both arms. With respect to LDL reduction, which was the primary efficacy endpoint, there was basically an 18.1% reduction in the ITT population, intention to treat, and in the on-treatment group, basically almost 20%. If you look at other reductions in other lipids, CRP was lowered significantly, apolipoprotein B, non-HDL, and total cholesterol were all reduced significantly and maintained through to about 52 weeks. So this would basically suggest that the addition of bempedoic acid on top of a high-intensity statin is safe and can give you a further almost 20% reduction in LDL cholesterol. Well, there are no recommendations for clinical practice yet, because the drug is an investigational compound. There are a number of other studies with bempedoic acid that will provide an evidence base of close to 4,500 individuals by the end of this year. And one would anticipate that at that stage there will be a desire to ask for a lipid-lowering label. And those kind of things take about a year and a half, and nobody knows if they get approved or not in that timescale, or whether more data is required. And if it is approved, then it would be an oral agent, and depending on the price, your first choice is obviously a statin, your second choice is ezetimibe, but in people perhaps where you can't afford a PCSK9, this might be an add-on therapy, or in people with statin-related side effects, this in combination with ezetimibe could give you a 50% reduction in LDL. So that's, I think, where it is likely to fit in when and if it's approved. It should also be noted that there is a large ongoing outcome study which is assessing LDL reduction through this approach on cardiovascular outcomes. So we wait for that in about 4 years. Well, I think the key things are that All of the patient populations where we felt there's unmet need are being studied in the CLEAR program. The further ongoing very large study, which will take a few more years to report because it's event driven, you'll need about 1,000 or more events, is CLEAR Outcomes, and that will take about 4 years. It's about a third of the way or so through recruitment, but it'll take a while for that to report out because of the events. And that's the other key one, is not only that we will have shown safety in the shorter, smaller studies, LDL reduction in those studies, but that reduction is translating to reduction in cardiovascular events and with an even bigger safety profile.